Kia ora koutou. Thank you, Gayleen, for that inspiring update of what you're doing down there in Queenstown. That sounds a bit similar, your population, to our local population in Taupo, which triples in the summer months also. You can probably see up here the beautiful view that I face every day when I travel to work. I'm a bit lucky, I guess. I'm a nurse practitioner and I've been employed at Taupo Medical Centre for the past 16 months. Prior to that, I have worked within the healthcare home model of care as part of the extended care team, which we were privileged to hear from Pen and Shane this morning. So I have worked in this healthcare home model for some time now. I've lived in the Taupo Rohi for the last 15 years and I've worked in both the hospital and primary care settings. My experience is heavily in the management of long and chronic health conditions, particularly cardiac complaints. I love all facets of my work, but the thing that really floats my boat and gets me up in the morning is helping and supporting people who have difficulty helping and supporting themselves, or perhaps how we define it nowadays as a high needs population. Today I'm going to talk about a routine and preventative care strategy that I have been working on, aiming to improve the care that we provide at Taupo Medical Centre to our high needs population based in aged residential care. So just some statistics about our practice population. So we have about 16,000 patients registered in our practice. That's approximately half of the usual resident population of Taupo. It's a large practice. Our population is served by 9 general practitioners. Patients are registered solely with the general practitioners, and we have 2 nurse practitioners who do not have registered patients but assist GPs and the rest of the primary care team to help manage our practice population. We have 63 residents who live in 63 patients who live in aged residential care. Seems like a paltry amount, doesn't it? 0.4% of our practice population lives in aged residential care. But let's not sugarcoat it. These patients are of the highest need in our whole community, and that's nationwide. If we remind ourselves that rest home care, these patients are generally assessed as they're mobile and they can feed themselves, but they need assistance with personal care or supervision with activities of daily living. They've been assessed as unable to live safely in their own homes due to their disability or lack of informal supports. Continuing care, I used to call that hospital care, but continuing care is the new catchphrase. These people have a significant disability, usually in combination with multiple medical problems which require 24-hour supervision and registered nurse input for their care. Dementia care. You know, these patients require 24-hour supervision in a secure environment because of the nature of the disease. And our psychogeriatric care, we do not have facilities for this in the Taupo district. Patients would be required to move out of the district if they required that. But this is for people with behavioural issues, particularly around dementia processes or addictions. These are a high needs population. I want to paint to you a picture. This is Ken. Ken is a 91-year-old man who lives in aged residential care. As a young man, he bought a farm in Waihi, which was covered in native bush. He cleared that farm with a scythe and a flamethrower so that he could farm livestock. He had 2 draft horses, they happened to be twins, and he used those to hoe his paddocks, to plant food for his family, put up fences for the livestock and get firewood for the house. He built his house for him and his wife and his eventually 6 children. He was a very independent man who worked really hard. When he was 70, he developed lower urinary tract symptoms, ended up in hospital for what was presumed to be a prostate cancer. When they removed his prostate, he was latterly told that this was a benign tumour. However, 10 years later, he developed severe back pain and was found to have malignancy metastases in his spine. As a result of that interaction with the medical teams, he has a real distrust of medical professionals, and because of his pain and reduced ability to care for himself, he ended up in residential care. Prior to ending up in residential care, he hardly ever was seen in primary care. This is Dr. Turner, or Dr. Giles Turner. Now, he's a busy GP, husband, dad. This is his wife Sandy and his two lovely boys, Josh and Sam. Now, Giles, he's had a busy week this week. He was at a board meeting on Tuesday night, and he was at CME on Wednesday. On Thursday he was on duty, and man, it was busy. He's promised Sandy that he's going to be home on Friday night to take his boys out for a mountain bike. Boys haven't seen him all week. Sandy's dying to catch up with her mates for a wine on the Friday night. I think that's fairly reasonable that Dr. Turner gets home for that. This is Cindy. Cindy is a senior registered nurse who works at one of our local rest homes in Taupo. It's where she works where Ken lives. Cindy's a really hard-working nurse who manages her team of other registered nurses and caregivers tirelessly to meet their needs. Caregivers report to Cindy at 9:30 in the morning that Ken has had an unwitnessed fall overnight. He didn't tell anyone. He got up to go to the loo, tripped over his slippers and fell on his right side. He got up, struggled his way back to bed, didn't tell anyone. It's just a bruise. In the morning, the caregivers have noticed that he's got a very bruised hip, he's got a significant limp, and he's in quite a bit of pain. He's still mobilising with his frame, as Ken does, but his mobility is much reduced. Ken requests some extra pain relief. This is a big change to Ken's no pills policy. Cindy sends a fax to Dr. Turner for review. Ken is really, really unhappy with Cindy because he doesn't want to see a doctor. It's just a bruise, I'll be all right, just give me some Panadol. Cindy, however, is pretty mindful that she's got some contractual and legal obligations to report that fall. If she doesn't, heads will roll, her manager's going to be on her back, and what happens if it's a hip fracture? Who's liable then? Dr. Turner, he receives this fax after he gets back from his lunch meeting on a Friday afternoon. Those of us who use Indice might recognise what's happening on the other side, but what that's telling us is that there are no appointments available. What is Dr. Turner to do? Sandy and the boys, wrath of Cindy. But what about Ken? He deserves and incidentally pays for good care. I'm not going to speculate what Dr. Turner would have done in this situation, though I could probably hazard a guess. But I only want to point out that this scenario was commonplace at Taupo Medical Centre 18 months ago. Probably commonplace in lots of your practices as well, if you're honest. Whilst Ken's hip was possibly an acute presentation, we also have other contractual and moral obligations to our patients who live in aged residential care. So if we're talking about routine and preventative care, Ministry of Health set us out with some guidelines. Aged residential care providers must ensure that all residents that are admitted to an aged residential care facility need to be seen within 2 to 5 working days of that patient being admitted. Patients need to be assessed not less than 1 month. Every month those patients are meant to be assessed unless the RN determines that unless an RN thinks that that person could be seen longer and the GP agrees with them. Then they can be seen every 3 months. The resident's medication chart must be noted and signed by the GP at each review, and that we must be able to provide on-call medical services to patients at all hours. So I just did a bit of math. What does that work out for our 63 patients? What it actually equates to is a lot of time in a very time-limited primary care environment. 63 patients, they require a 3-monthly review at minimum. That's half an hour by the time you get your gear, drive to the rest home, see the patient come out. Half an hour is probably pretty fair for a review. That's 122 hours a year, 3 40-hour weeks a year, 2.5 hours a week, or 10 15-minute appointments every week for our 0.4% of our population. This is just for routine care. This doesn't include things like our our admissions to residential care, Ken with his potentially busted hip, medication management, advice, triage. Nurse practitioners at Taupo Medical Centre cover GP inboxes while they're on leave. We receive labs, letters, etc. as any other provider does. We also therefore receive faxes from rest homes. This is the way that rest homes within our region communicate with us. My interpretation of that when I was receiving these rest home faxes was that the templates were chocker. How are our GPs fitting this in? I certainly can't fit it in because I'm fully booked today. How am I meant to deal with this? I'm thinking these high needs patients are getting ad hoc care in a 5-minute visit during a lunch break because that's all we can fit it in. Clearly this was just my perception, so I asked my colleagues. I asked my GPs how do they feel that the care we provide to this population is going? What were their thoughts about this? Some of the things they said were that there was a lack of coordination. They were getting rubbish clinical information from the rest homes, that they only had time for brief clinical review at their 3-monthlies. Lots of grumbling about how much work this is generating and the requests we were receiving, ad hoc care, urgent requests were done after hours, lack of consistency of requests. Kind of fitted with my perceptions. So what did I do? I started a crusade for improved care for these high needs population. And what I did is I audited 2 weeks of faxes. Faxes, like I said, are the way that we communicated, and it seemed to me that we were getting truckloads of them. So over a 2-week period, we had 62 faxes from a rest home. Lots of faxes. Lots of admin time trying to sort through those faxes, putting them to the GPs. Lots of GP time responding to the faxes, or not. And the fax burden means that you just kind of think, oh, when I get to that. After I audited this, I suggested to our leadership team, I said, look, we need to catch up with aged residential care providers and see what they think about the care we're providing to these people. You know, what do they say? We've got all these grumbles. What are they saying about what we provide to them? So we had a meeting with them and we asked them, what was their perception of care? They said that care was rushed. It wasn't uncommon for doctors to turn up at 7 o'clock at night after their duty to see their 4 patients. They don't have registered nurses on at 7 o'clock at night to be able to follow around the GP when he's doing his routine preventative care round at 7 o'clock at night. These patients are often in bed then. Scant clinical notes, not meeting the requirements for auditing, multiple faxes they were having to send to try and get some feedback. Urgent faxes they had to chase up again and again and again. There was one example that a nurse was concerned that this patient was rapidly deteriorating, perhaps from something happening in a patient's abdomen. She had to ring, she faxed 3 times, rung twice before getting a response. Admission appointments often outside the required Ministry of Health timeframes. They have to be seen within 5 days. They would often not be seen till 8 or 9 days later. Medications, especially our complementary or non-funded meds, being incorrectly prescribed on Medimap, so the nurse is having difficulty administering those. And really poor visibility of what goes on in primary care when patients independently book appointments. So the Quality Crusade continued. I grouped the themes from the feedback from those 2 meetings, one with my GPs and one with aged residential care providers. Communication, documentation and clinical time were the key big ticket items that were common amongst both groups. As a result of this, I wanted to drive change. Now the healthcare home model promotes people working at the top of their scope, doing things that float their boat. These are a high needs population group, all with chronic conditions. And as a nurse, I felt that I was in a good space to be able to provide care to this population for routine and preventative care. I talked to my GP colleagues about this, and that was discussed at a board level. They were all very happy for me to take on this role. Okay, so time was the big factor, yeah? So in order to address timeliness as a practice, we made some changes within our practice, but we also asked of some changes from aged residential care. So what we did is I asked that faxes, there was lots of discussion about blinking faxes, you know, is it the best way to communicate in this technological age? There's some hesitation from aged residential care about privacy and insecure links. This is a work in progress. We still have faxes, but they need to be to us by 10:30 in the morning. All of these faxes now come directly to me, and I have some dedicated triage time for incoming faxes. What I tend to use, and within our practice we have dedicated phone triage slots, so I tend to use those to go through. There's still quite a lot of faxes. To triage them, do these patients need routine care? Do they need acute care? Is this a 3-monthly review? Does it just need a phone call to reassure the nurse that they're doing the right thing? Acute reviews are booked on my template. I often have spots available because I don't have registered patients to my name. So I'm much more likely to have an open slot than Dr. Turner is, for example. So I have more availability to be able to book in acute reviews if they're needed. Non-urgent reviews are also booked on the on my template, often to coincide with other visits. So if I'm going to see one person for a 3-monthly review, well, I might as well see that routine wound while I'm there. 3 monthly clinical reviews are pre-booked in advance, and typically I do 1 clinic a week, 3 to 4 patients at a time. What also happens is when I go out to see these patients these 4 patients for their routine review, is now the nurses have a list. You know, can you just do this, and can you just re-prescribe that, and what do you think about this? So often I see 4 patients, but I might deal with 5 other things while I'm out there, which prevents 5 more faxes coming into our practice. Just by the very nature of being in the rest home and being visible, we have improved care and less traffic coming into our practice. Friday phone up. I've just started this in the last month. What we know is that we tend to get a whole lot of faxes on a Friday because nobody's around over the weekend. So what I've done is I've started to call every practice, every aged residential care provider in our region on a Friday, anything happening, anything need doing prior to the weekend. And it's amazing what does need to be done prior to the weekend. So-and-so is deteriorating, they're end stage, palliative. Could you consider prescribing a pump for them so that we don't have to harass the on-call doctor over the weekend? So we'd be able to provide these proactive steps to this high needs population without having to get 4 faxes and stress out the on-call doctor over the weekend. Communication was one of those other things that we recognised was an issue. And I'm sorry, probably this is quite difficult to read from the back, but this was you know, some of the stuff our GPs were talking about, poor care or poor information being provided to base our decision making on. And this actually says this lady had a complaint of gas trouble. It's making her upset. Could you please chart something for her? What do you chart? What do you do? Yeah? SBAR. I'm not sure if, I suspect a lot of people in the room would have heard about SBAR, but SBAR is a handover tool initially evaluated by rapid response teams in Colorado hospitals to improve safety. SBAR is a communication model that standardises information sharing, which allows for short, organised, predictable flow of information between healthcare professionals. It's been tested in lots of clinical scenarios with improved patient safety as the common outcome. We all know that nurses love the narrative, the descriptive approach to telling you about a patient's history or complaints. Doctors, they only want the nitty-gritty. SBAR aims to try and close that gap between the two. So SBAR stands for situation. So I developed this for our aged residential care providers. You know, what are your symptoms? How concerned are you about this? Is it urgent or not? Give me a bit of background, you know, what's the history of this patient? What's going on for them now? What are your findings? What are the observations, you know? How about assessment? What have you been doing from an assessment perspective? Do you think they've got a UTI or do you think they've fractured their hip? What have you done? And what do you want me to do about this? Do you want me to call an ambulance, or do you think that they just need their Panadol prescribed regularly? I gave this information to all providers in the region and encouraged them to use this as a template for future faxes to our practice in an attempt to improve communication. This was taken up readily by the team, and this is a true fax of what's happened afterwards. So you can see here that the nurse has said we'd prescribed some codeine for this lady. I'd prescribed it later in the day at breakfast time. However, she was stiff in the mornings before she got out of bed, so it was a waste of time prescribing it then. It's better to get her up and going first thing in the morning. Can we switch when it's prescribed? Easy. Sorted that out in 2 seconds, contrary to the lady with gas trouble, which took a little longer. Clinical documentation was another bugbear from both our GPs, but also from our aged residential providers. Now, this is some true documentation before. You can see this is, I guess this is could be a reflection of the doctor's let's just get to the nitty-gritty on the before side, or the flowy descriptive words of a nurse on the right. However, the feedback I'm getting from my colleagues in aged residential care is that that flowy narrative description much better meets the requirements of auditing and follow-up for other providers coming in after us than the before ever did. Aged residential care also had some concerns about the charting of medicines. Now, we're lucky in the Taupo region that we have a clinical pharmacist attached to our extended care team. We also have a very experienced clinical pharmacist employed by the DHB to help with high needs patients. I've been fortunate to be able to use both of those pharmacists to help me to manage the polypharmacy that is a real problem in this population, but also around some of the de-prescribing decisions that we should be having, mostly at these 3 monthly reviews, to try and prevent complications in these population groups. You're probably asking, what about the GPs in all of this? How does that work? What tends to happen is I go out and see these patients for their routine care, and I'll take a laptop with me, I log into Indice, I type my notes there. While I'm there, I'll task the GP, say, check out my notes, I'm worried about this, what do you think? Please give me some feedback. If these patients are stable and I'm unconcerned, check the notes for your information. There's often, I'm a nurse, my experience and background is chronic conditions, but I am no biomedicine expert, my GPs are that. Therefore, the collaboration between the two means we have better care for all of our patients because we come at it from different angles. We're just different experts. I had a patient recently who had terrible shoulder pain, osteoarthritis, lots of issues going on with that. All the usual strategies weren't working. She had had a steroid injection into her other shoulder with a really good effect, and that's all she really wanted. Tasked the GP. GP went out the next day, gave her an injection. Much better care for that lady. I re-audited our faxes for 2 weeks in October after implementing this process, and I was really nervous about this because it seemed to be there was still a whole heap of faxes coming in. Thankfully, there was a little bit of a reduction, 45 faxes versus the 68 or whatever it was before. But what it did show was that there was a reduction in the medication and advice slot and the 3 monthly reviews. We got 3 faxes for 3 monthly reviews because what happened is I'd sent out an email the week prior, can you please send me all your patients that require 3 monthly reviews, and there was 19 patients due for that in the next month. That gave me the time to be able to proactively manage those and book them appointments in slots that weren't being used, not acute, not when we were at our most frantic. So there was an improvement. However, I'm also mindful that this still remains a high needs population. They still have needs of primary care and we still need to meet them. So perhaps I was being a bit optimistic in seeing, 2 faxes. So what do my GPs now think of the way we provide age residential care? They love that the clinical pharmacist is addressing some of the polypharmacy that's difficult to assess in a 5-minute lunchtime review. We're getting good feedback from me to the GP so they know what's going on with their patients. Majority of the work is handled efficiently. Remembering most of this is around proactive care, there's still some of that acute stuff that I may not be able to fit in, that therefore the GPs need to. Or the lady with a cortisone injection in her shoulder, I'm not clinically skilled enough to be able to do that, so I get the clinically skilled ones to do that. There's less stress on GPs to fit in urgent visits, better time management. This one cracked me up. The most significant single improvement in the quality of my work environment since stopping providing maternity care 15 years ago. There you go. What does age residential care feel of nurse-led interventions? Vastly improved continuity of care, improved response times to faxes or requests for advice, more time taken to evaluate and assess patients. Clinical documentation and prescribing is improved. Acute concerns are dealt with much more quickly and effectively than they were previously. There's a structured process for patient reviews. When I was writing this up, if you're thinking about all the stakeholders in this picture, there's somebody I haven't surveyed, and this is the patients themselves. Age residential care, patients by their very nature are used to kowtowing to GPs' models, traditional models of care, so seeing a nurse practitioner is a bit of a novelty. Lots of these patients are palliative, many are demented. It's difficult to evaluate this population. However, moving forward, it's something that I really need to do. I just need to think about how I'm going to do this. This is a work in progress. We're trying to evolve and better our service. Surveying these patients is next on my list. But what about what is next for us in Taupo Medical Centre for these populations? I really want to get rid of those faxes. We're working on that. Do we have a secure email? Do we give age residential care ability to access indices and task GPs or providers, so we're not getting this constant run of faxes that our admin staff then have to deal with. Improved documentation. We need to continued work on that SBAR tool and getting it embedded and integrated. I think there's still some old faxes lying around, so sometimes we still get some of those other ones that I showed you earlier. Every time I go there I try and chuck them out so that they're only using the SBAR ones. Yesterday while I was out, the age providers have just implemented a new patient management system, so they've gone from the big folders of information to online notes. The one that I saw yesterday was called eCase, and it was amazing. I could just cut and paste my notes straight into there, no faxes, nothing. It was done and dusted and clearly auditable and visible to all the providers that are seeing that patient. Hopefully we get more of that in the coming months. And we need to continue tinkering to get the time aspect of this right. What do the templates look like? Do we have enough slots to manage those 10, 15-minute appointments? Do we have enough time to triage? Do we have enough time to see urgent appointments? The population is not stable, it's evolving. So we need to keep looking at that to keep improving the service. The why we do this is because it's about the people, the people, the people. There's three people that we need to consider in this. We need to consider Ken. He deserves good care. We need to consider Giles. He also deserves good care and a good work-life balance. And poor old Cindy, she does too. We know that we have an ageing population in New Zealand. Our boomers are coming to the fore. We have an ageing GP population. We're not going to have the numbers of GPs available to provide care to Ken and his ilk. We also have not enough aged residential care nurses available to provide the care of this tsunami of patients that is going to evolve into aged residential care. It's kind of like a perfect storm. Nurse practitioners, other allied health professionals, clinical pharmacists, nurse prescribers are really well placed to provide routine and preventative care to this population. If your practice hasn't thought about it, then I implore you to do that. Thank you.